So welcome everyone to this afternoon session sponsored by the College of Social Sciences and Public Policy. My name is Will Butler. I'm the moderator for today. I'm the Master's Program Director for the Department of Urban and Regional Planning. And I want to welcome you all here for this discussion on COVID-19 and inequities in our society. I think the theme of the day is really to understand how crises have a way of shining a light on the shadows, the problems that get ignored when things are perhaps going well. Um, Crisis also creates opportunity to reflect, to adapt, even to push for more substantive change, transformative change. And the COVID-19 pandemic is no different. It puts into stark relief inequalities within our system that are laid bare before us, aspects of our world that we ought not be proud of. It's not unlike what Hurricane Katrina did back in 2005, or a range of other crises that we've had over the years. So our panelists today are shining lights on these inequities that have become more pronounced and visible during this pandemic. And I want to welcome them. We are going to have first Dr. James Wright, who's an assistant professor in the Askew School of Public Administration and Public Policy at FSU. And his research specializes in policing and law enforcement, agency management, and race. His research has examined the impacts of body cameras and racial disparities in policing, the impacts of providing public access to police misconduct allegations, police officers' decision-making during police stops, and how physical appearance impacts use of force and community protests, among other issues, including the work that he's going to be sharing today, providing an overview of. And to give everyone a sense of the format of the day, there's a Q&A button in the bottom section of the Zoom format, and you're able to press that to post questions if you have them. We're going to let each presenter present their work, and then and it'll take anywhere from 4 to 8 minutes, and then we will have a Q&A opportunity at the end of the presentations as a whole. But if you have questions that come up for a specific presenter, please note that in the Q&A section. Our second presenter of the day will be Dr. Patricia Homan, also an assistant professor in sociology, and she's associate at the FSU's Pepper Institute on Aging and Public Policy and a research affiliate of the Center for Demography and Population Health. Her main interests are health demography, gender, stratification and inequality, social psychology, and quantitative methods. And her research explores how gender, socioeconomic, and racial inequalities in American society shape health and well-being of the population and of individuals as they age. And third will be Dr. Kerry Fang, who's an assistant professor in the Department of Urban and Regional Planning with me. And she is specialized in land use and comprehensive planning, and now is focusing on economic development and how that affects land use. She studied economic systems and land development in the United States, Australia, China, and Russia. And in doing so, addresses questions such as why are some regions rich while others are poor? What policy tools can create jobs and innovation? All with the goal of pinpointing how to improve communities overall. Dr. Fang is working on multiple new research projects, including her work on COVID, which she'll share with us today, some of those early results. And then Dr. Daniel Fay is associate professor in the Askew School of Public Administration and Public Policy at Florida State. And his research interests include organizational theory, diversity issues in public management, veterans policy, policy diffusion, and higher education policy and management. And he'll be sharing work on COVID and gender inequalities. So I'm going to open it up now to Dr. Wright to open the conversation, and then we'll move through each of the panelists in turn. Thank you.
Thank you, William, for the introduction. I thank the College of Social Science and Public Policy for this opportunity. And when we think about COVID-19, we've seen the sharp disruptions that it's created in American society. So today I'm just going to tell you a little bit about my research on COVID-19 and how it affects particularly the Black American population, speaking in the United States, of course. So when you think about COVID-19, federal, state, and local leaders have responded by adapting practices and protocols geared toward mitigating the spread of the virus. Social distancing rules, everything we're abiding by now, curfews, mandatory stay-at-home orders. But despite sort of these human and economic and medical resources being distributed to fight the virus, marginalized and underrepresented populations remain particularly vulnerable, right? So these vulnerable communities include people such as low-income individuals, people of color, indigenous people, senior citizens. And part of my research, when I thought about COVID-19, I thought about the impacts of COVID-19. This was very early on, is we know that whenever a policy is administered, whenever something happens, we know that the African American population, the Black population in America is always disproportionately impacted by it. And it sort of ties to my broader research agenda, which is to understand how institutions and organizational, especially systemic racism, which is embedded within those, impact people of color, particularly Black Americans. And so what I did is with a colleague, we wrote sort of this theoretical piece at the early front end of COVID-19, trying to make it, put it on everyone's radar that COVID-19 is going to have a disproportionate impact on African Americans. And as the data sort of borne out, since we originally wrote this piece, we've seen that it has had very detrimental impacts on African Americans. So we started to theorize, well, what are the reasons why, and so some of the policy solutions we can do to address this. So when we think about some of the reasons why there's disproportionate impacts of COVID-19 on Black Americans, think about healthcare inequality, right? So despite African Americans having some of the worst health outcomes in the country, white Americans have better access to resources and treatment within the healthcare system. And that's essential for leading a healthy lifestyle. So for example, Blacks compared with whites are seen by fewer specialists. Blacks compared with whites are more likely to die by diabetes and lack of intensive care. And Blacks have a higher rate of cardiovascular disease and mortality. But not just healthcare inequality. We think it's sort of the systems in place, and we think about segregation, overall health, and food insecurity in the Black neighborhood relative to other populations. So as a result of residential segregation, African Americans, who are most of the time, and what we've seen recently, in fact, is that residential segregation is at levels pre-1970. So we're talking about right when the civil rights movement happened, where segregation has increased to where it is now. So when we think about segregation, we know that Black neighborhoods have poor schools, they have poor resources, poor access to social services. So what does this produce in these Black neighborhoods, you ask? Well, we have lower educational attainment for Black Americans. We have more negative interactions with the police, which is what I study. We have increased mortality rates, and segregation has also resulted in increased health challenges for Black Americans. In particular, what we've seen from the literature is that Black Americans who live in highly segregated areas generally have lower health outcomes. And we know that people that are predisposed are more likely to experience COVID-19. So we see that institutions, organizations, and communities that are in place are disproportionately going to impact Black and Brown, and in particular, my research is looking at the Black community. But not just healthcare inequality, not just segregation, but also food insecurity, right? We know that Black neighborhoods are some of the poorest census tracts in the United States, and food insecurity poses a serious risk to these households. We have high levels of poverty in these census tracts. And what we see is that when they can't afford healthy food options, they tend to buy more processed food and smaller quantities of food because of financial restrictions and lack of disposable income. So what we saw at the beginning of the COVID-19 rush, while everyone was out getting toilet paper, everyone was also out there buying food. And if we know that these poor census tracts don't have the ability or disposable income to buy these food, they're left at the tail end of the distribution of what food is available. So they don't have the opportunity that you, me, and others have to buy this food that may not be as processed or high in fats or high in sugars, which then just reproduces back to the cycle as to why they aren't healthy in standards that we think of today. And finally, we see that there's a lot of underrepresentation. I mean, you can think about any field for Black Americans, but especially in government and medical professions. So for example, multiple states have administered drive-through testing, right, early on. However, they didn't think about how that policy had ramifications on different subgroups or different populations. If you just originally have drive-through testing, African American households or Black American households are 3 times more likely than white households to be without a car. So if the only place you can get a test is a drive-through and yet you don't have a car, how do you have access to get tested for COVID-19? So what I'm saying here essentially with my research and with my colleague is that these systems and these institutions continue to perpetuate the same inequalities for Black Americans as any other sort of policy. And if we think about national incidents such as COVID-19, that's why we see sort of the effects and the detrimental effects that COVID-19 is having on the Black community. So then we propose, 3 sort of policy recommendations for legislators and administrators to consider when we think about COVID-19. So what we said is, one, which actually we have seen now, is they collect and release demographic data related to COVID-19. right? We need to understand at state level, at a local level, at a federal level, what's going on with COVID-19 and who's being the most affected by it. Now, what we pitched is a national data set. And as we can tell, sometimes um, com- there's a lot of combating between federal, state, and local leaders. So that would be good, though, that national data set is publicly available to everyone. Secondly, we think if you really want to target the Black community, you got to engage nonprofit organizations that are led by African Americans in these communities. So oftentimes what we see in Black communities is that a lot of nonprofits are led by white individuals in these communities. But if you really want to understand the pulse of the community, you need to go to these nonprofit leaders and church organizations that are serving the community. So they need to be readily available to understand that there's a COVID-19 outbreak in this community. Your community is disproportionately impacted, and you can help us solve the solution, right? So that brings up other issues of finances and resources, right? Which we can talk about later, but you have to engage locally with the community leaders that are really trying to help the community. And finally, we have to establish election contingency plans that curtail voter suppression. So the optimist in me believes that we will establish these things to curtail voter suppression, but the realist in me, and based upon previous elections, sees, and what we're seeing now is that voter suppression is alive and well, and it always has been, similar as gerrymandering and redistricting. So those sort of things are important for election contingency plans if we assume that our representatives are responsible to the civilians. So those are the things that we see are important. And then finally, we got to reduce digital inequality, right? A lot of times local governments are putting out information from a digital aspect, but we know there's a very stark digital divide in the country. And what do we see is that it affects a lot of Black American households. So those are some things that we can do to begin to address how the COVID-19 disproportionately impacts Black Americans. And I will stop and turn it over to my colleague, Dr. Homan.
Thanks, James. Go ahead, Dr. Homan. It's great.
All right, that was a fabulous presentation from Dr. Wright. I'm also going to be talking about some of the same themes, but more from a medical sociologist health disparities perspective, because I've been studying racial inequality in health long before coronavirus happened. So let me just share my screen. Okay, so this talk is about how structural racism is a fundamental cause of racial and ethnic inequalities in health generally, and specifically in inequalities in COVID-19. The COVID-19 pandemic has caused an enormous amount of suffering in the US and around the world. And by now it's clear that Black and Latinx older adults have been hit the hardest. So the panel on the left shows the death rates by age category, and you can see that it's particularly deadly among those aged 65 and older, who account for approximately 80% of deaths due to COVID so far. And if we focus in on that age group, age 65 and up, on the right-hand panel, you can see the death rates broken down by race. And you'll see that Latinx older adults have death rates that are twice as high as whites, and Black older adults have death rates that are 3 times higher. And we really cannot understand these dramatic disparities without accounting for the role of historical and contemporary forms of structural racism. So what do I mean by structural racism? Well, I'm not talking about overt acts of interpersonal discrimination, intentional mistreatment. Instead, structural racism refers to systemic racial exclusion from power, resources, opportunities, and well-being. Structural racism is embedded in major political, economic, medical, criminal, legal, and social institutions. And we can observe it as large racial inequalities in things like political representation, wages and unemployment, medical treatment, incarceration, housing and schooling conditions tied to residential segregation. So medical sociologists consider structural racism to be a fundamental cause driving racial inequalities in health because it shapes a whole constellation of more immediate health risk factors and health promoting resources that individuals have. So structural racism can affect health through many, many different intervening mechanisms. In the case of COVID-19, our recent research identified 3 key proximate mechanisms through which structural racism operates as a fundamental cause of racial and ethnic inequalities. Risk of exposure, weathering processes, and healthcare access and quality. So I want to explain and talk through this with a couple of quick examples. First, structural racism in the forms of residential and occupational segregation and vast racial wealth disparities shape living and working conditions in ways that put minorities at greater risk of COVID-19 exposure and limit their ability to practice physical distancing. For example, Black and Latinx adults are overrepresented in high contact occupations in food, retail, service, transportation, and health industries that have been categorized as essential, and this puts them at elevated risk for workplace exposure. They're also less likely to have access to paid sick leave and remote work options, and they're more likely to rely on crowded public transportation. In terms of living conditions, segregation and wealth inequalities create a situation in which racial and ethnic minorities are more likely to reside in densely populated, economically disadvantaged neighborhoods, which Dr. Wright explained how those can be harmful for our health. And they're also more likely than whites to live in crowded and multi-generational households. And this can increase their risk of exposure to COVID-19 due to limited ability to isolate from household members who've been exposed. So not only are older minorities at higher risk of exposure to COVID-19, but they're also more likely than whites to experience serious complications and death as a result of getting the virus. Why? Well, partly because they're more likely to have underlying chronic health conditions like cardiovascular disease, diabetes, and obesity. Now, we might be tempted to just leave it at that, but it's crucial to recognize that this higher prevalence of underlying conditions among minorities is actually driven by structural racism through a process health disparities researchers call weathering. So weathering refers to the wear and tear that happens to the body as a result of cumulative exposures to racism-related adversity and stress over a person's entire lifetime. So these racialized exposures can increase blood pressure, physiologic dysregulation, inflammation, and accelerated aging. And that has serious health consequences long-term. So by the time Black and Latinx adults reach middle age or late life, their health status has already been compromised by racism in ways that put them at higher risk for COVID complications and mortality. The third key mechanism through which racism drives unequal COVID disease burden among racial and ethnic minorities is unequal healthcare access and quality. For example, because of their overrepresentation in low-wage jobs, racial and ethnic minorities are less likely than whites to have employer-sponsored health insurance, and this creates significant barriers to accessing and affording medical care. We also know from numerous studies that minorities receive often a lower quality of care when they do access the healthcare system. Studies show, for example, that minorities have longer wait times before seeing a provider, receive less information from their doctors, and are less likely to have their pain appropriately diagnosed and effectively treated. On top of that, residential segregation shapes the distribution of patients across hospitals such that the worst hospitals in terms of quality and cost end up caring for twice as many older Black patients as the best hospitals. So what can we do about it? Well, we can certainly intervene on some of these mechanisms with COVID-specific temporary policies that will provide things like supplies, benefits, and workplace protections for essential employees, and things like stimulus checks or other forms of economic relief for families. And this would be a great start. But it's equally important, or more important perhaps, to realize that unless we address the underlying fundamental cause, which is structural racism in our institutions, minority communities will continue to bear a disproportionate burden of suffering and excess death. throughout the pandemic, but also long after. Because while it is true that the COVID-19 pandemic is an unprecedented health crisis, the inequalities it's highlighting are longstanding and deeply rooted in American society. Prior to COVID, my research showed that structural racism was linked to a variety of other non-infectious health problems, including chronic conditions, physical limitations, depressive symptoms, and overall poor health. Some of the intervening mechanisms were different than the ones I've described today, but the fundamental driver of racial health disparities is the same. So we need bold, transformative actions in order to truly achieve health equity. We need social policies to dismantle structural racism, and that is what's going to produce better population health in the long run. This includes policies that promote things like universal health care, desegregation of schools, jobs, and neighborhoods, raising the minimum wage, criminal justice reform, and so on. I will say that systemic change is difficult, but it's not impossible. And we can start right now by voting to raise the minimum wage in Florida because that's on the ballot. If we're committed to change, we can create a healthier and more equitable future for everyone. And I just want to say thank you to my collaborators who work on this research with me at Duke University and at University of Nebraska.
All right, thank you, Patricia, Dr. Homan, and now to Dr. Fang.
Yeah, Patricia, could you stop sharing so that I can share my screen?
Yes, one sec.
Great, thank you. So switching gears a little bit, my research focused on more on the economic impact of COVID-19, and specifically this study I'm going to share with you focus on the retail stores, which are among the hardest hit sectors because people were no longer able to go to the retail stores and go shopping as usual. And a lot of retail stores are going out of businesses. Even the big names that we know, like that we have been shopping there since we're kids, are have filed for bankruptcy, like JCPenney, Neiman Marcus, J. Crew, name a few. So this poses a serious challenge to local economic development planners because our streets are losing their functions. The picture you see here is a street in New York City, used to be super crowded, super busy, super vital place. Now it's nearly empty. And we are losing characteristic of a community because we're losing all that mama papa stores that have close connection to local communities. And if they go out of business, what we have left are empty spaces. And fundamentally, it's going to threaten the economic vitality of cities because retail sectors are really a key component to the economic functionality of cities. If we think about a city and its main street, there are lots of retail stores there. So immediate policy responses are needed, and local economic development agencies actually are diligently trying to design small business support programs right now, and some of them are already put into place. But in the process of designing such policy response, there's a big challenge, which is we are lacking a good understanding of the magnitude and the spatial distribution of the impact with real-time data. Many of the economic data are really sluggish in time, so they won't be available until half a year later, but that's not going to help us now. So my research really help at that end because I'm using real-time data, the cell phone locational data, to track where people travel, and if they travel to a retail store, I will record that, and I aggregate such data weekly at the county level for all the counties in the United States, with a study period from October 1st, 2019 to the end of July 2020, and compare how COVID cases versus non-pharmaceutical interventions, including emergency declaration, stay-at-home orders, business closure orders, and reopening affect people's visit to retail stores. So here's the results. So every 1,000 COVID cases decrease a retail store visit by 0.2%. Emergency declaration have a negative impact 2.3%. Stay at home had the largest negative impact, decreasing the retail store visit by about 8%, business closure by about 4.6%. And even after reopening, the visit to retail store continued to decline at about 4%. So we're not really overall seeing lots of recovery there. There are also a lot of heterogeneity across geography. So I have compared urban versus rural areas. What I find are urban areas are hit quicker and harder, but they show a clear sign of recovery after reopening, relatively fast speed. So they may really experience a wave-shaped recovery. If we are able to put together some financial support for them right now immediately, they may bounce back relatively quickly. In contrast, rural areas respond slower to COVID and the emergency declaration and stay-at-home orders, but they continue to decline even after reopening. So the type of financial support rural areas need is really longer term. I have also compared counties with 80% or more resident white versus counties that have more minority residents. So what I find are minority counties are hit much harder from the beginning, from when the states put together the emergency declaration. But minority counties also started to show a sign of recovery after reopening, not really very fast, but some early sign of recovery. So again, if minority counties can get a quick dose of financial support, they may be able to recover. I also compared high income versus low income counties. What I find is the pattern in high income county actually shows more of a voluntary feature, meaning that after emergency declaration, there is not a decrease, but an increase in retail store visits in these counties, meaning people going to retail stores, most likely groceries, to stock up. And then after stay-at-home orders, these counties experience a big drop in the visit to the retail store. So after they have stocked up, they are able to stay at home and avoid retail store visit as much as possible. But that pattern is not present in low-income counties, likely because residents there don't really have the luxury to quarantine at home. They may need to go to work every day. So if they had to go out and work every day, it's not that much meaningful for them to avoid a retail store visit on the way home. I have also compared the mama papa stores in our communities versus chain stores. So what I find are mama papas are hit 1.5 times as hard compared to chain stores. And especially mama papas in minority counties are hit 2.5 times as hard. And the top chain stores, they actually gain customer visits after emergency declaration. So these are the places that people go stock up after the emergency declaration, and they actually gain some business from there. And after reopening, I see customers slowly returning back to mama papas. So the gap between mama papas and chain store after reopening has significantly narrowed. So these findings are real time and are able to support our policy making. So it can provide a first estimate of what is supposed to be the magnitude of the financial support, and also who should be eligible to apply. So the top 10 stores should not be eligible to apply for the financial support. They are actually getting some businesses. On the contrary, the mama papa stores, especially those in minority counties, should get the priority. And they also shows us how we can roll over this program in time, because some of the places are hit harder from the beginning, but they started to show some sign of recovery. So these can be the places that get the first wave of support. And after they have partly recovered, then we can get some revenue and some partly paid back loans from them to roll over this program in longer term for other places, which might be in a more sustained period of economic distress. So that's all for my research, and I'm turning over to my colleague, Dr. Fang.
All right, thank you, you, Dr. Fang. Dr. Fay, you're up.
Thank you. Thank you all for joining us today. So I am going to present two related studies that I have been working on with two of our top doctoral students in the department. And we focus on the government response to COVID-19 and how these governmental responses can create some unintended consequences and how we should prepare for those. So the first study that we did is with Luciana Polishuk, and we are examining the governmental response to stay-at-home orders and how that's related to gender-based violence in Argentina. And then the second study focuses on labor relations for public sector employees during times of COVID. So in the administrative response to state lockdowns, we were interested in this idea of increased vulnerability of gender-based violence in Argentina. And gender-based violence has been shown by several different studies to increase during lockdowns, and it's evidenced by an increase in demand for services in places like the US. But some also say that the increased prevalence of gender-based violence is demonstrated by a sharp decrease in reporting due to the difficulty in reporting. And so gender-based violence is intimately related to patriarchy and this dominant form of masculinity that uses violence to subordinate socially subordinated gender groups. And it's very much related to the marginalization and invisibilization of labor by women. And what's important is that women, as Dr. Wright mentioned in his initial talk, representation matters, and women are not well represented in crisis management teams. And so oftentimes the governmental response to crises overlook women at the beginning of the pandemic and the gender implications of governmental response. So Argentina is an interesting case because as a country, they have adopted systematic policy changes to address gender bias in violence prior to the pandemic. And they did this at a national level and through a coordinated response. And so in their response to COVID-19 lockdowns, they also followed similar suit. And so they adopted multi-level and cross-sectoral response to protect these marginalized gender groups. And this was really in response to a 39% increase in calls to domestic violence helplines and sustained rates of femicide that were in contrast to a sharp decrease in other crimes throughout the country. And so the national response was to expand the communication strategies or communication resources for women that may be women and other marginalized gender groups that may be susceptible to gender-based violence. The national government, which was led by the Ministry of Women, Genders, and Diversity, also tried to target the systemic causes of gender-based violence by attacking the dominant form of masculinity and targeting the male perpetrators of gender-based violence rather than trying to react to those who may be surviving gender-based violence. They also were very cognizant of making sure that there was a continuity of services so that protective orders would be maintained even if the administrative continuation was not possible due to lockdowns. And the innovative communication strategies also tried to reconcile the fact that many people who are susceptible to gender-based violence are in close contact, close home quarters with the perpetrator of violence, and therefore they need some nonverbal way to communicate or to report gender-based violence. And so they did this through a red mask campaign, where individuals could go to a local pharmacy and request a red mask as a code word to report that they are experiencing gender-based violence. So that was one of the strategies. They also worked primarily with private industry, like WhatsApp and Facebook, to develop these other nonverbal weight reporting tools. The national government also tried to coordinate with provinces to generate model policies for those provinces to engage and address these issues. And one of the ways that they did this was through these innovative communication strategies. So here's an example of one of the messages that was sent through Facebook. And as you can see, the translation below talks about the systemic causes of gender-based violence, not just reacting to instances of gender-based violence, but trying to address the marginalization and the invisibilization of labor that exists in a domestic setting. And so that was one of the innovative strategies that they used. And the idea behind this was that Argentina was addressing the systemic causes of gender-based violence in a way that other governments have not. And we argue that this gender lens in crisis management should be adopted early in most crisis response. And that would allow for governments to address these unintended consequences of their policies. In the other study where we're talking about labor relations and inequality, we offer some recommendations for how to protect some of the most vulnerable groups of employees. Our recommendations are as follows. We want to initiate negotiations early and often so that we are not perceived as self-interested and reactionary. We want to see this as a collaboration with policymakers and leadership, and not necessarily a combative approach, even though labor relations, collective bargaining is very combative. We also want to make sure that we show the strength of our collection by mobilizing our workers immediately and showing the size of the workforce. And we wanted to recommend the prioritizing marginalized groups of employees. And this varies based on the government response, right? So if we have frontline workers, they may be paid higher than other communities or other groups of employees, but they are most affected by this crisis event. So we may prioritize those that have resources, those that have less pay, but we also, based on their working conditions. We also wanted to make sure that we integrate government response into our negotiations to expect that future shutdowns would happen and that governments are going to be financially strained. So we wanted to prioritize non-resource-based protections. So having the idea of furloughs as an opportunity for governments to respond to protect workers rather than having full employee and pay protections in our negotiations. And then finally, we want to formalize the agreements through a ratified MOU that oftentimes unions don't do. And so leadership and policymakers cannot honor the agreements that they have followed into. So basically, the government response to these huge crises can create bad outcomes for our citizens and our employees. And we need to address these early, often through a multi-level and coordinated response. So just To end, I'd like to recognize the two students that worked on this work, Luciana Polishuk and Adela Gadimi. They are the PhD students that are really doing interesting work in these areas.
Thank you, Danny. I appreciate that overview of that research. So I wanted to open up to questions. I'm going to start, but then I encourage people to use the Q&A balloons in the bottom little tab, and you can add your questions, and we will get to those as quickly as we can and get to as many of them as we can. The first question that really comes up for me is, in the field of urban and regional planning, we like to think about sort of what's happening in the world right now. What would a better world look like? And then how do we get there through policy, planning, interventions, investments? What are the things that need to happen to make the world a better place? And as I listen to all of you, there's a lot of suggestions that you already are laying out for us about how to address everything from structural racism to gender-based violence. And I wonder, does this disruption of the pandemic sort of change the context for planning and policy? Are we looking at new planning and policy ideas, or is it is this disruption kind of a window of opportunity that opens up space to make progress on existing policy ideas, to maybe launch it forward a little faster? I wonder if you all would be open to reflecting on that question.
I can start us off.
All right.
Absolutely, it is an opportunity to rethink how we do things. So from my perspective on the economic development policy, one thing that's popped up is this inequality across geography that has been exacerbated by COVID, but it is already there and has not been sufficiently addressed. So the competition from big box stores to driving out the mama papa stores out of businesses, and especially in the minority places, that communities that these businesses are driving out of their business, and then the owners there from the minority communities no longer have their way of living. And that is something we need to address. And in the CARES Act financial support programs that across the nation, the local economic development agencies that are diligently designing now, that should be a priority. In the state of Florida, the governor's office has been designing such programs. During the summer, Dr. Sam Daly and I have been involved in the early stage brainstorm process of this, and hopefully our research can support them, can give them some evidence-based information so that they can design a more effective program. And also it guides our longer-term economic recovery. So another component of my research I haven't really talked about too much today is to diversifying the local economy. So the Florida economy has been hit hard, partly because our economy are too much focused on tourism. And that is something we need to consider. And COVID actually provided that opportunity for us to consider that. And the governor's office are thinking about diversifying the economy, developing other industrial clusters, probably in the Tampa Bay area, so that we can have a more healthy economy with various different industries working together, not solely focus on one single industry.
Yeah, great. Thanks, Dr. Fang. Drs. Wright, Fay, or Homan, you want to chime in on new ideas or pushing forward ones that have been on the books for a long time, been in people's thoughts, but haven't had the traction?
Yeah, I mean, I think that we do have opportunities to be innovative, and some governments have shown a willingness to do that. In Argentina, there was kind of a slow progress towards removing gender bias in society and in government. And this opportunity, this situation gave the government an opportunity to push for removing systemic gender bias in households, because people are, spending a lot of time together, and we need to rethink the gender roles. And so I think, yes, it gives us an opportunity, but Argentina was making progress prior to this, and this just kind of, provided steam in that engine.
All right. So I've got a couple more coming in. So I'm going to pivot to the conversations that are happening in the chat. One specific to you, Dr. Homan, you discussed how Black communities are at higher risk for exposure from COVID-19 due to more dense population of communities and households. Does systemic racism play a role in why Black communities are more likely to have multi-generational households due to poverty, or ultimately increase their exposure to COVID-19?
Yeah, that's a great question. I will say that the dramatic structural racism that we can observe in wealth inequality certainly plays a role in the housing conditions. If you look at the amount of money the average a white person has by the time they reach retirement compared to Black or Latinx older adults, there are dramatic differences. And so that definitely plays a role in how many people live in a household and what their housing conditions are like, for sure. So I would think of the type of structural racism that's driving that particular risk of exposure to be mostly wealth inequality.
Thank you.
I actually say for 1 minute, your previous question about this current moment and new ideas and moving forward, I think that as a health disparities researcher, I've seen these same inequalities time and time again with every health outcome I've looked at, and there's been just growing commitment in the research community to advance health equity and to come up with policies that are going to reduce structural racism. But I do think it's a unique opportunity for the public to see it and make it visible and get involved and become passionate about it, especially with the Black Lives Matter movement and all the things that have happened this summer. In addition to COVID, the sort of combining of those things has made it really salient. And I think when we start with some of these more immediate COVID specific policies, and if they work and if people see them and experience them, they're going to say, why don't we have this all the time? Why don't we have paid sick leave all the time? Why don't we have universal health care? And so that will be motivating to make larger changes going forward.
Yeah, thank you. All right, any other thoughts on that topic? All right, I guess one of the things that strikes me as you all were talking is particularly, Dr. Wright, when you were describing the intersections between segregation, housing, food insecurity, access to libraries, to school, to education, right? That in some ways it comes down to what is a right and what do we make people pay for in the market. And we've said food, you got to pay for. We've said healthcare, you got to pay for it, except for the elderly or extremely poor. Housing, it's not a right, you got to pay for it, right? And so we've sort of constructed a system within which inequalities are laid bare by the way the system decides who gets what and at what level they get it, based on wealth, existing wealth, or income as the only other ways to get it. So that's a dynamic that is not addressed, and often in these policies, it's sort of a fix to the market rather than how do you pivot to something that you're suggesting, Dr. Homan, such as universal access to healthy food, universal access to healthcare, and that would be a transformative type of policy shift. All right. Another question that comes up is sort of forward thinking, prognosticating about the future of the Black community, that COVID-19 has set back the Black community significantly. About how long will it take to recover from the effects of COVID-19 and systemic racism, the two being related, of course, and mutually reinforcing? What are the steps that need to be taken to do so?
I'll start. And not to, so my first thing is the Black community never recovered from slavery, right? So the Black community never recovered from Jim Crow. The Black community hasn't recovered from segregation. So if we think that they're gonna, and I'm not saying, I'm saying if we think they're gonna recover within 5, 10, 20 years, we're not, right? We're gonna see residual effects long time for Black and Latinx people, right? But at the other end of the spectrum, I think you said, what are some things that we can do, I guess you said, for them to recover?
What are steps that can be taken
Yeah.
to address the recovery that's needed?
Yeah. So, I mean, as Dr. Homan said, right, we have to acknowledge that systems and institutions are designed inherently to create disadvantage and inequality, right? So if we first can acknowledge that, then we can start to deconstruct those institutions and systems and reconstruct them in an image that's more universal and more egalitarian, right? So at the short term, in terms of a policy frame, we need to think about holistically, how does our policy impact very disadvantaged communities, right? Are we designing policy where it's going to start to impact people that are marginalized at the intersections of these subgroups of populations? So we can think about some of these universal health care, right? We can think about reparations. We know there's a bill in California to advance reparations. We can think about, ending educational and residential segregation, right? Criminal justice policy. We can go on and on about criminal justice system and how it creates winners and losers and puts people in cyclical cycles as revolving doors. We can, but the thing is, and especially for political leaders to get behind it, is going to be our framing. How do we frame these policies in a way where we're not just giving away things, but bettering American society? So if we frame them around bettering American society, people are more willing to work on things, right? When you frame criminal justice, not that, oh, Black and brown people are in the system, but they could then contribute to society if they're not in the system and contribute more to our economy, then people across aisles will be more likely and more receptive to that language.
And I'll pipe in and building on that. Something I teach my students about in my health policy class is targeted universalism as a type of policy. So what that means is that we have a universal goal that we all want, like Dr. Wright said, bettering society. So that's why something like minimum wage, it's not a race-specific policy, but it's universal. We have this goal of everybody having enough money to live, but it's targeted in that it's going to disproportionately benefit racial and ethnic minorities who are currently overrepresented in low-wage jobs. And so actually, there's some great new research coming out of Berkeley. Some economists did an analysis about the Fair Labor Standards Act in 1966 and how raising the minimum wage reduced the racial earnings gap by 20%. So that's huge. So not only is it like bringing up people who are suffering, but it really can create a more equal society.
Great, thank you. So another question, do any of you have access to information about how physicians and doctors who are minority or marginalized have been impacted?
So I know that for the Filipino community, they have been disproportionately hit hard, especially nurses, 3-to-1 average relative to white nurses in terms of COVID-19. And that's not being talked about at a national stage as it should be, right? Because they're a smaller segment of the population, yet we know that they always tend to filter into those jobs, right? Sort of because of structures, but they're being disproportionately impacted by COVID-19. So that's something that needs to be talked about.
Yes, I'll add to that. There is some new data on COVID-19 outcomes among healthcare providers, and we are seeing pretty big racial inequalities in those, in part because minority doctors are serving minority communities who are harder hit, and also because within the healthcare system, people are not equally distributed across jobs on the basis of race. So some of these high contact nursing and janitorial jobs are employing far more racial minorities and putting them at greater risk than a radiologist who's sitting there looking at a computer all day.
And then another one is about SBA loans. Oh, it just disappeared from my, oh, hang on, I think you get it. All right. So about researcher evaluations on the SBA loans and Leon Cares funding and how that was distributed at the local level. For example, the number of small businesses, minority businesses, and so on, women-owned businesses that were awarded compared to bigger companies or agencies. And there was, of course, a lot of turmoil and media coverage about how lots of large franchises were pulling a lot of this money early on. There's a lot of give back. So I think that's part of the source of this question, sort of navigating this terrain between the small businesses, and that often might be a source of wealth generation, income generation for local minority communities and women. Kerry, you want to jump in on that?
Yeah, that's a really great question, because that's really something that has been on the radar of the researchers and policymakers for a while, of how these things are really implemented. I haven't seen the published data on how exactly they are distributing and what type of business are getting those money. But I do know that it's really in the conversation during the policy design back in the summer, because we really that's partly why we study business of different types, because we really want to know which type of business are hit hardest. So to say small business, there are different definitions for small businesses. So what are the business actually are hit the hardest, and if they hit hard, are they going to bounce back really quick, or it's going to be a longer term impact? That's really quite important. And the question on the bigger companies getting the resources, that's a real concern, because it has happened. Like there are programs that in design, they do say, oh, you have to be a small store, but a small store belong to a chain brand may eligible for that type of grant as well. And it used to be in some of similar type of support programs, it's the majority of the stores getting the money is actually from a big chain brand. And that's why, like in my research, I particularly separate chain stores versus mama papa stores, so that we can clearly see the chain stores, the mama papas hit much harder than the chain stores. And if the financial resources really limited, we should think about maybe the chain stores, any of their stores cannot really apply for the type of support. So if there are data published on how this is really implemented right now, I'd be very curious to see if the actual implementation are in line with the initial thoughts during summer in the policymaking conversation.
Great, thanks. And then I think this will probably be our last question. This is for Professor Wright. When compared to the response of Hurricane Katrina, would you say that the government or emergency management programs have improved, or they remained stagnant, they didn't add or gotten worse, is what I would add, with their response to addressing the specific needs of Black communities?
So, so when you think about the response from administrators from Hurricane Katrina, they completely dropped the ball. And we have continued to see the effects, right, with education, right? A lot of people left and they're in Texas and, they're in different places. With COVID-19, since it's still playing out, I would say as of now, it's relatively stagnant, but there's an opportunity to be better. And I'm hopeful that they will be better towards the Black community. But what we've seen traditionally, whenever there's some sort of natural event or natural disaster, is that the Black community has traditionally been hurt disproportionately, right? So Hurricane Katrina, we saw what it did to the Black community that was already poor, already marginalized. And with COVID-19, we've just seen the same effects. The thing is now we've seen a sort of tailoring off of it, but that's just because of the uptick early on of the Black community. Now we've seen that other populations are being affected by it. But the thing is, we have an opportunity, say, in a few weeks, depending on the election, to actually sort of really target our response to COVID-19 on populations, especially the Black population that's been disproportionately affected by it. So we have an opportunity, because we're still battling COVID-19. Let's be real about that. We're still battling it. But as of now, reflecting X number of years later, I would say it's not as bad yet, but we have an opportunity to make it a better response.
Great, thank you so much, Dr. Wright, for that assessment. couldn't agree more. I think we're right in the middle of it. I wanted to thank, first of all, our panelists, Drs. Homan, Wright, Fay, and Fang. Thank you. Appreciate it. I'm the only one who gets to clap, but there you have it. And then thank you also, Rachel, for running our tech side of the equation. Couldn't do it without you. Dr. Rollinger, Associate Dean Rollinger, thank you so much for helping put all of this together. Really appreciate the support for that. And thanks to the College of Social Sciences and Public Policy for offering up the space of the webinar and for being supportive of doing this kind of work. That's, as I see it, it's cutting edge and extremely important to address these questions. So thank you all. And thanks to all the attendees for coming today. We appreciate it.
Thank you, guys.
All right.
Thank you, everyone.
Thank you.
Thank you, everyone.
Bye, thanks.